And then other hardware, if you have a separately implanted pacemaker, we used to see that a lot, in the past before we had pacing capabilities and devices, but now we still can see it if someone has a subcutaneous system and a separate pacemaker. But if you have more leads in there, you want to make sure they're not and you didn't extract a lead, make sure they're not in contact with that previously implanted lead, because you can get some, chatter. And then oversensing of extracardiac signals, things like the diaphragm, myopotentials, and EMI from external things like electrocautery, or noise or artifact from lead problems, lead fracture, insulation problems, or a problem if the screw isn't tight enough in the header. So the very basics, and I suspect pretty much everyone in the room knows about this, but detection, SVT discrimination, and therapy for fast VTs is a lot of these studies for evidence-based programming focused on. So detection, and you could program a few different detection rates, for 2 different VT zones in one, VF zone in some of the devices. Detection duration, that the language isn't exactly the same between manufacturers, but the number of intervals to detect, or seconds in some devices. SVT discrimination, meaning that you'll withhold therapy if the device sees this as SVT. So you want to avoid inappropriate shocks, right? And then there's sudden onset stability and morphology, been around for a while, we'll talk about. And then you have separate dual chamber discriminators. And then treatment for fast VT. We know in the EP lab, when we used to do a lot of EP studies, we can pace terminate VT, the device, and even at very rapid rates. So this is a way, and we see them in standard programming in devices is to program on even in the fast VT zone. So how does this all work? Just basic concepts in the VF zone. When you set your rate cutoff there, it's a probabilistic counter, meaning it doesn't have to be every RR interval that the device sees. It needs to be, for example, if you have it programmed 12 out of 16, that's really short, but we don't. But as an example, you have to get 12 out of 16 that meet that detection rate cutoff to really start detecting that arrhythmia. I know in contrast, in the VT zone, it would be the number of intervals to detect, and those are consecutive. So if you have, say, 16 beats that are all meeting the criteria, that would be something that would get therapy. And so this is, so the concept over the years, so we will often program the devices like 30 out of 40, because for the number of intervals to detect, because we saw that still, we can get some unnecessary shocks. And then even in the setting of someone, for example, non-sustained VT that terminates spontaneously, we don't want to treat that, because there's always a chance if you pace into it, you could accelerate it and then induce VF and the patient gets shocked. But the same thing for noise. So if you have problems with noise on the device, one of the things is prolonging that detection duration. That'll help reduce the chance that that noise will receive therapy. And so, there's all these things that do this. Obviously, your lead, a lot of things are involved in that, right? Your lead needs to be in a good position. A lot of factors, how you're sensing, is it dedicated bipolar just from the tip to ring, or you sensing something from the tip to the coil? Again, making sure that that coil is far enough that across the tricuspid valve, so you don't oversense anything in the atrium P waves. Then there's, the device itself has amplifiers and filters and things like that, and then how you program it, and that's what we're talking about now. And then there's, things for detection and then redetection on whether or not you'll get therapy. So, for example, the very simple things that we look at for SVT discriminators and things that you could program on the device is sudden onset. That's, how rapidly did it start? Is it sinus tachycardia that starts slowly and gradually, or did it come on all of a sudden? That's VT, or could be SVT, like AV node reentry. Is it stable, meaning how irregular is it, right? So is it something like AFib, or is it something like VT? And we know sometimes VT could be a little irregular, but most often, if it's really irregular, it's AFib. And then you could look at the electrogram morphology, and this can be in both single chamber and dual chamber devices, how different that QRS, the intrinsic electrogram, is from that present in sinus rhythm. And then there's separate dual chamber discriminators. So, so you could set these up for each zone. But the one thing to remember that in the SVT discriminators we use for initial detection, right? The only one that can be used for redetection is stability. And so, again, the purpose of this is to look for something irregular, like AFib, but you're usually more regular in VT. So what you do is, the only potential, problem with this is if you have a really fast AFib, really good conduction down the AV node, the amount of irregularity, the difference from, beat to beat would be less, so that might be where the device discriminators may fail. Or sometimes you can get a little irregularity in the VT, particularly when you're on antiarrhythmic drugs, but not so much of an issue. And how does it work? So that, different companies and different, devices have different ways to do it, and there's different algorithms. And for example, if you're looking at stability, you could look at, in this case, like the first, so 4 intervals. So when you get to 3 beats, so 3 beats meet that rate cutoff of the device to detect it, and then the 4th beat, is compared. And if you're looking, if you have it set at, say, over 50 milliseconds is the standard. If that differs by more than 50 milliseconds from the previous 3, that is considered, unstable in terms of irregularity. And so this really relies on this gradual increase, a concept in sinus rhythm to get to sinus tachycardia, and an abrupt increase in rate with VT. But again, it's not specific for, ventricular arrhythmias, as you can have SVT like that. Now, the one exception, if you have a VT that's very close to the rate cutoff of the device, you might get that sudden onset. Say if you have it set at 170 beats a minute, say the rate of the VT is 160, you might get sudden onset below your detection rate, and it might speed up because maybe the patient's getting hypotensive and their catecholamines are increasing, and you might gradually cross that zone. So that may not be detected as a sudden onset in that case. And so this is looking at sudden onset, looking at the average of 4, the preceding 4 to the current 4. And if you have it set at, say, maybe 81% of the cycle length, it'll compare that and decide, is this, am I going to reject it? Is it SVT or is it VT? This is just showing you that kind of example of that gradual, you had a sudden onset below the rate cutoff of the device. And it was classified as SVT based on this criteria because it was then it just gradually increased where it's detected in the VT zone. And then morphology. So morphology is a good criteria so that it saves a template of what the intracardiac electrogram looks like in sinus rhythm, or your intrinsic rhythm. It might be AFib, but usually sinus rhythm. And then when you go into this, arrhythmia that meets that detection, cutoff, then it'll look and compare that to what it has stored. And there's different ways that, again, the different devices do that. And this is just an example of where you compare it against the match threshold. And in this case, it's nominal. And if it scores less than 70%, it's identified as ventricular in origin. And that's for, it looks at 3 of the last 8 beats in this regard. And this one, I don't know why that happened, but so this is just showing, or was supposed to show you, it's just showing you the templates, what the device sees as the template of the current rhythm compared to what the stored template was. So you're comparing the current intracardiac electrogram appearance to that in sinus rhythm, and it matches, and it'll withhold therapy. This was an example of SVT. It was very, very similar to the underlying stored electrogram, but so it rejected therapy and did not deliver therapy there for VT. And so these different discriminators, even for a single chamber device, it doesn't have an atrial lead, are really excellent and really successful in identifying SVT and rejecting therapy if it's SVT, so you don't get inappropriate therapy. And so now there's also, on top of that, if you have a dual chamber device, there are dual chamber discriminators. So that's kind of looking at things, what the atrium is doing, what the ventricle's doing. So if the atrial rate is greater than the ventricular rate, equal to the ventricular rate, or if the ventricular rate is greater than the atrial rate, so the latter being, AV dissociation, that's the easiest for, so that's going to be VT if you have AV dissociation. If you have the atrial rate greater than ventricular rate, that could be, you could have dual tachycardias, right? You could have atrial tachycardia or atrial fibrillation in the atrium, and then, ventricular tachycardia in the ventricle. So it looks at that association and looks to decide whether or not it's conducted AFib versus a dual, ventricular tachycardia and underlying atrial rhythm. The harder one sometimes can be with the atrial rate equal to the ventricular rate, and it will. It may be harder to look depending on what the VA times or the association of the ventricular and the atrial rates are. So that might be more difficult than the other ones for the device to discriminate on occasion. Now, when you look back afterwards, you could kind of figure out, right, that this one was easier because this one is the V rate greater than the A rate. That was AV dissociation. That's detected as ventricular tachycardia. This is one that is SVT. So the atrial rate is equal to the ventricular rate. You could see the atrial rate and the ventricular rate being identical on the left. But you could see that the VA time is very, very short there. And this was AV node reentry, and that's why you had such a short VA time. And therapy was withheld. Now, the other thing to think of, and I think we don't really think about this a lot when we're implanting, but we should be, is, you're using, if you have a dual chamber device, you're using that atrial lead to help with discrimination. So where that atrial lead is can be important because when you're in the appendage, in some situations, you could have a very large ventricular electrogram, or if you're not in the appendage and you're closer to the tricuspid valve, you could have a large, you don't want it to be, certainly don't want it to be bigger than the V to be bigger than the A. But even if you see a very large far field ventricular electrogram, it may impact on SVT discriminators because you get 2 of them for every 1 V, right? So you don't want that. So you want to make sure you put the lead in a good place. Now, if you have an atrial lead dislodgement, that obviously can impact on sensing, but usually it turns out to be the oversensing of the far field R waves that are a problem. And you might misclassify, VT and SVT in that regard. And that is probably one of the more common, sources of failure of the dual chamber discriminators. Not that it happens often, but when it does, that's often sensing of that far field V. So you want to minimize those when you put the device in minimal far field ventricular electrogram. So what's nice is if you, in many places, will have the device company representative in the lab with you, and usually they'll, let you know, oh, there's a far field V, and that's really big, and it's, it has a potential to be sensed. So the dual chamber algorithms, there's, PR logic and rejection algorithms, and it works in a variety of different ways. It applies just for the initial detection, not for redetection. And it looks at these patterns of the PR relationship, AV association, the rate, and the regularity to distinguish this. And PR logic is, doing a lot of this, right? On its own, considering the pattern association regularity within the rate. And this one here is dissociated. You can see on the on the bottom there, you can see the A's are a much different rate than the V, and that's kind of an easier one for everyone to figure out, including the device, to know that it's that it's VT. So, and there's different orders in the algorithm, right? So you start out, first of all, you always have to meet the detection cutoffs and the number of intervals to detect. It's not going to, even go through any of these algorithms until you meet that rate cutoff. That's for VT or VF. But in this case, in the VT zone, if they are dissociated, then it goes. You're detecting VT in that case. And if they're not dissociated, so is it, going to be SVT or not? It'll withhold therapy, and then if it doesn't meet those criteria, then you detect. And then so if your atrial rate is greater than the ventricular rate, so this is the order, and then wavelet is applied. So wavelet is at the end of the order of the algorithm. And so, programming all this on and not, adding a lot of things. And so I think a lot of people sometimes will add, stability or sudden onset on the right, but really, my experience is you don't need to add any of that, and that can only cause problems down the line. So just, letting the device do its thing. what I'd actually never, years ago, we used to use this because we didn't trust the devices so much, but there's something called timeout. It's called different things in different device companies, but it means that after a certain amount of time, the device is going through this discrimination to decide is it SVT or VT. And then you're saying after 60 seconds, no matter what the device thinks, just give therapy if they're still in that rhythm. You really don't need to do that. I always program this off. Certainly there may be a rare situation you put that on, but you're just saying you don't believe it. But it's algorithms that have really been proven to work and work very well. And you don't want to get therapy for SVT, and because SVT could be sustained and last more than a minute or two. So I program that off. And so is there data? And I'm going to just very briefly kind of run through the data. And the answer is yes. Many studies. Many done, many years ago, and in kind of sequence. And so everyone thought initially, can we use anti-tachycardia pacing in a VF zone? And that kind of rate cutoff for a VF zone that might be a fast VT, but it meets 220 beats a minute or whatever you have it set at or faster. Is it safe to give ATP? And the answer is yes. And so most of the episodes in that zone, ATP was successful in 72% of these fast episodes. So it's something that you could, why not try it? Why would you not try it, right? 72% of the time you're going to be successful. And so there's lots of studies, not going through every single one, but there's lots of studies, and these are some of the major ones. Some are randomized trials and some were observational studies. And they looked at different criteria in your programming. So making very intentional programming for your particular patient is important, but there are some standardized ways to do that have been studied, in randomized trials. And some look at just rate, some include detection duration. That's at like 30 out of 40 beats, for example, ATP in the fast VT zone, or in the monitor, do you put on a monitor zone or not? And so some of that data I want to just present to you because I'm not sure everyone in the audience is aware of this. So PREPARE was one of the earlier ones. And this was by Bruce Wilcoff, who is a giant in the field in electrophysiology, unfortunately passed away this past year, but has contributed so much to what we are today in devices. So this is looking at just primary prevention patients, 700 centers, and they used historical controls. They didn't randomize. So, you can argue that that's not the best way, but it was one of the earlier studies here. And this was what we do standard now, but they, 30 out of 40 beats for your initial interval to detect, people thought, maybe that's too long. I want to treat faster, again, but the devices now, we used to be worried about defibrillation energy requirements, but they're so good now and they're high output, and we don't really worry about effective defibrillation therapy. And this shows us that we don't. So we're going to prolong duration to reduce shocks for these self-terminating episodes of non-sustained VT, for example. Avoiding therapy for slower VTs by putting that fast VT zone at like 182. The monitor zone, it has a monitor zone. It won't give therapy in that zone at 167 is how they decided here. And to try burst pacing in that fast VT zone. So this particular study showed, and this is just looking, the top one is the PREPARE programming and the historical controls are the bottom. Bottom line, shock episodes were reduced by 63%. And that was actually a reduction in both appropriate and inappropriate shocks, meaning that some of those episodes were just non-sustained VT that terminated spontaneously, and only 3.6% of patients actually received an inappropriate shock, compared to, if you remember in the first slide, a lot of SCUD-HEF patients got inappropriate shocks, right? That, because we didn't have this information back then. Made it RIT, as I think most people have sort of heard about this a little bit, but this is 1,500 patients with dual chamber or CRT devices, had primary prevention devices, and they went into 3 different programming options. It was randomized to where what was considered standard for the time, not standard for now, but a rate cutoff of VT of 170. These are people never had VT before. This is just primary prevention. A 2.5 second delay. This was a different device. So they did it by seconds instead of number of intervals to detect, and programming on onset and stability. And then the VF zone was just programmed at 200 beats per minute with a very quick delay of 1 second. And then the second possibility was programming just a monitor zone, but your treatment zone would be in the VF zone at 200 beats per minute with a 2.5 second delay. And then the third one is kind of, again, when this was, it was kind of a bizarre thing at the time, but saying wait 60 seconds at 170 beats per minute, but then do 12-second delay at 200 beats per minute and put your VF therapy zone at 250. So different kind of thought processes, and some people thought, oh wow, this is going to be really bad, and we're going to have a lot of problems, but that's not what happened. We saw that there was a reduction in inappropriate therapy through ICD programming compared to conventional therapy. Both that high rate cutoff and the delayed therapy had a marked reduction in inappropriate shock therapy. And in addition, as a little bit of a surprise, I think, that it was actually a reduction in mortality, a significant reduction in that high rate cutoff compared to the conventional, rate cutoff. So kind of a little added plus that you might actually, increase survival. That's pretty cool. So Advance 3, that you say, well, that's just primary prevention, but Advance 3 is another trial. This one included secondary prevention patients, because when we're kind of thinking of how to program our devices in the lab, what about the secondary preventions? And so this focus was on that long detection interval of 30 out of 40. People are saying, well, they've had VT, I don't want to wait that long maybe, but this is looking at that. And this study showed that even in these secondary prevention patients, that there was a reduction in both anti-tachycardia pacing and shock therapy with this long detection interval programming. So what other features? And there's lots of other great features. I mean, these engineers at Medtronic and elsewhere are really brilliant, right? They come up with these things to reduce T-wave oversensing. Program that on. I program that on all the time. For options in devices, you would want that, right? And they have different. There's a decay and sensitivity for some of the other manufacturers. And then the lead fracture surveillance, lead integrity alert, or noise detection algorithms are in devices. So a lot of this stuff we don't have to think about anymore. But over the years, a lot of these things will come out of box programming, but not all of them. And you might have to adjust certain things for your particular patient. In the past, when you get a device approved by the FDA, it's approved with those settings, and you can't just change your out of box settings without doing the next study. So it's a little bit easier now than it was years ago. But you may still see people coming in, and we see them coming to the hospital with multiple inappropriate shocks because they're programmed some bizarre way. But we can prevent that. In most cases, you can't prevent to make it zero, but we can get down really, really low and to the 2 to 3% range, even certainly less than 5%. So this was one that again included both primary and secondary prevention patients, and looked at reduction in therapy with modern programming. And you can see here, once again, it was down. Inappropriate shock rate at 1 year was 1.5% with either CRT or dual chamber devices, and 2.5% with single chamber. So again, these algorithms, these enhanced detection algorithms are really great. And this one also included the things like added T-wave oversensing, and it added, some of the other factors in 30 out of 40 and all those things. And in that particular study, then you say, well, maybe everyone's passing out now because I'm waiting too long. And the answer is no, they're not. The arrhythmia syncope is no different during follow-up, and it certainly is doesn't quite make the statistical significance, but there's no increase in mortality either. So we're not doing anything bad. And then if you look at, so there's always these meta-analyses, and we see there's like a zillion meta-analyses for everything now, but so this is just looking at meta-analysis. And again, you could see inappropriate shocks overall are reduced, and in most of the studies there was a reduction overall. And then mortality, if you just look at the non-randomized studies and the randomized studies together, there was, favors this therapy reduction programming, these using discriminators and everything. If you look at just the randomized studies alone, it does turn out to be a significant reduction in mortality. So we're doing good things. We want to do it, and we want to prevent those patients, most of all, from getting, inappropriate therapies. And syncope, again, is no different. Now, there was a consensus statement by the Heart Rhythm Society back in a multinational document back in 2015. So this, there was a little short update. Many of the faculty may have been on this document. And it comes up with these specific recommendations based on that data. For primary prevention patients, again, trying to make recommendations for different companies is sometimes a challenge, right? Because there are different studies and different programming options. So, it's saying basically don't treat really fast, put those detection intervals out. And, for secondary prevention, some of these, programming options are good. And then, program on ATP, why not, right? If you can terminate it without getting a shock, that's important. And it tries to give some specific recommendations in that regard. So in addition to all that, you have to consider the individual patient, right? Are they young and active? Are they more likely to get sinus tachycardia? Like I have a hypertrophic cardiomyopathy for primary prevention. You're going to want that rate cutoff really high, right? Because they can get sinus tachycardia. And in some patients, if they're really athletic, they may not be with hypertrophic heart disease, but with other heart disease, you might want to even get them up on a treadmill to see if can make sure they don't get their rate cut off anywhere near it if they're going to exercise. And then beta blockers, young people don't really like beta blockers, but if they do, because of the prevalence or the incidence of atrial arrhythmias, even if they don't have them yet, can be high over time in people with heart disease. You want to have some beta blockers around, and most of people who have LV dysfunction obviously are on beta blockers anyway. And then if patients have slow VT, obviously they can have a VT ablation. And so it's telling you program on the noise activation algorithms, lead alerts, all these kind of T-wave oversensing algorithms. And then actually, Chuck Swerdlow, I think, is kind of made a comment here. He did this paper too. So you're going to have individual patients that don't fit into the box, right? There'll be people that are outliers. They may have, they're sensing algorithm, they're sensing the site where they are, might have smaller R waves, there may be some other things. And so will this fit 100% of the patients 100% of the time to prevent, therapies, or is there any risk of anyone ever having something that's not detected? So the answer is, yeah, nothing's perfect, right? But just to be careful. So especially if they're non-EP docs, you notice that they'll use one device company only, because to learn all these different kind of algorithms and how to program a particular device is difficult, right? It's hard to remember all that over time. And even for those of us who do this all the time, you have to kind of think, about that particular patient. So this is a patient here who is an older device, but had intermittent dizziness. And we see these patients come in because, remember, a lot of these devices are not followed by EP docs. They're followed in the community. They're still being seen in the office and reprogrammed, not necessarily by us. So you could see on the left, you have the real-time electrogram, your atrial electrogram, and then you have the far-field electrogram, and then you have the tip to ring is the third one down, and then you have the more distal, you could see, the far field, the CAN to SVC electrode. And then on the right, what do you all think the right hand strip is? If you just look at it, this is after the fact, you're looking at it, right? And what do you think that one is? VT, right? That's our classic AV dissociation, and you have the A's doing their thing and the V's doing their thing. And if you see down there, you see the sensed intervals, and they're like, they're 330, 340, so it's pretty regular. But you see this little marker channel on it, and so it's like resetting it and saying, maybe it's not VT. Why is it saying that, right? So this device came in, the patient came into the ER, and this is how they were set. So this is showing you that the enhancements on this device is intentionally programmed with stability on and sudden onset on, and T-wave, noise time, and plus, it had, the other program parameters that you see there. And if you look at the specific episode, data, again, you could look on your plots there, and you can see they're dissociated. And so that's what that all looks like. A monitor zone is at 133, but this is well above 133 beats a minute. So what would you do next? Obtain a chest X-ray to check lead placement, increase the VT rate to 310 milliseconds, to turn off sudden onset instability, replace the pulse generator, or turn off PR logic. So PR logic there is the program parameters on the top part there on the, maybe I have a pointer actually doing. Yeah, I do. So here you can see Yeah, so here you have the PR logic is on, and then this is on here, and here are your rate cutoffs, 176 and 214. What would you all do? Chest X-ray? Anyone else say anything different? So you're thinking something dislodged. Okay, and why?
It showed, it's looking at it that way because there's some wobble.
Mm-hmm. Yeah. So he said, I don't know, he didn't have a microphone on at the time, but basically because there's, so there's two different reasons. If stability is on, it might be detected. It doesn't say stability on that part of the strip, but it certainly could see that. I think it's irregular, but at some parts, or sudden onset. Was it because this is the rate cutoff that's kind of close to the rate cutoff of the devices? Did it come on suddenly or not? And it's saying no, it didn't. So yeah, and I think the bottom line is that you really don't need to program on, and I don't program on. I can't think of a case recently, but stability and sudden onset I leave off. When you have pure logic, these algorithms are really good. So you don't have to, the only thing is that you might program stability. So if someone has a lot of AFib post-shock, I guess you could say, I want to be able to, because the only one that works post-shock, it's not going to go through, PR logic won't be on the post-shock. I don't know why they were programmed on, but that would be the only thing I could think of. Someone might want to do that, program it on stability for that reason. But so yeah, exactly. Okay, so let me just briefly run through the bradycardia here. So this is a patient, 72, coronary disease, an AFib, ischemic cardiomyopathy, had an ICD for primary prevention. His EF has decreased from 30 to 20%. And he's on guideline-directed medical therapy, which is a good amount, and now he has an EF of 20%. And they did another cath, and everything was okay there with his stent. And you could see here that he's had ventricular pacing almost 47% of the time, and MVP is on. And MVP, algorithms will, mode switch from, dual chamber to, single chamber. So you did what you could if that PR interval gets really long. So that's what we see there. And so what would you do next to improve his heart failure symptoms? Would you do an AFib ablation, AV junction ablation, increase the program paced AV delay, or a CRT upgrade? CRT upgrade, agree. So for this patient, a CRT upgrade is we know, and I'm going to breeze through this data, but that chronic RV apical pacing is bad, increases heart failure, increases AFib, increases mortality. And we do have that great algorithm, MVP works, but there's a point, where patients have conduction disease and need pacing, right? But pacing in someone who already has a cardiomyopathy is not a good thing. We learned that from David, that pacing the ventricle is, and this was a surprise at the time, again by Dr. Wilkoff did this, that it was a bad thing, made people have worse outcomes. And this is for first hospitalization or worsening heart failure. And then what percentage? So we have a lot of studies that were looked at in this study, over 40% compared to, less than or equal to 40% was the number there in terms of, and then this was from made it to 50%, pretty close to 40%. And then this was a pacemaker study. It looked at dual chamber pacing versus single chamber pacing for pacemaker patients. And here it looks like, again, that 40% number kind of bore out is survival free from AF too. So not just heart failure, but also worsens AFib. And then now we have, and we'll talk more about, but a conduction system pacing. And this was, one hospital did conduction system pacing, the other one didn't, but now it is using that 20%, greater than 20% pacing cutoff, which might worsen outcomes. This was freedom from death, heart failure, hospitalization, or upgrade to BIV. So you want to use, if this stuff doesn't work like MVP, either atrial pacing ways to minimize RV pacing, or adaptive AV programming delays in some of the devices, Boston Scientific and others, or these mode switching algorithms. All these things are ways to reduce RV pacing in someone with a dual chamber device. Now we have, data to support, upgrading to a CRT in this case. And this is just to show you the progression of the guidelines. The initial document, we did expert consensus statement was saying, use these kind of algorithms. The next one, says that also. And then the Brady pacing guidelines from 2018, it says you can upgrade to either CRT or HIS bundle, but now the most recent document is the HRS. It's the first guideline that HRS initiated. It's a multinational document here too, with APHRS and LAHRS, but looking at patients who do have a high degree of RV pacing, class 1 indication still for CRT using BIV pacing, because we have tons of data to support that, but also allows you. And substantial now is not just 40% defined as in prior guidelines, it's 20 to greater than or equal to 20 to 40%. It's a kind of, that's considered substantial pacing, that, using some kind of conduction system pacing now, left bundle or HIS bundle pacing can be used in addition to CRT. And then, so the last, I'll mention CRT, evidence-based programming. This is a non-ischemic cardiomyopathy, chronic heart failure, and left bundle, and had a CRT implanted. So it was a perfect candidate, had that done, but still really not much in the way of improvements of heart failure. So we say, oh, CRT doesn't always work. And there's lots of reasons why CRT may not work. And part of it may be the way we program, part of it may be other patient factors. So he had this EKG in the office, and I'm not sure if you can appreciate, you can see that, there's certainly the right bundle pattern, a QS and B6 and lead 1. And then the underlying rhythm, you could just take a peek at what you think that is. And his device was interrogated, and this is how it's programmed. And again, you're seeing a lot of, so this was an older device, but now you can't program out an MVP for the CRT here, but 67% of the time the patient was pacing. So that's a lot. And so what is the most, and here's some other data, you get so much data from these devices, which by the way, you also get on remote monitoring. So we do a lot of that management remotely now, which we have a breakout session for. But here, I'm gonna ask you, what do you think is the most likely reason for a poor response to CRT? And we're gonna assume that based on that EKG, the lead was probably in a pretty good position. You had a good morphology right bundle pattern with a QS and B6 and negative in ones, it was probably somewhere lateral. Do you think, well, I told you it's not number 1, but poor LV lead position, suboptimal frequency of BIV pacing due to rapid rates in AFib, frequent PVCs, or a poor response because patients with non-ischemic heart disease have a poor response? And rapid atrial pacing. And you can see, and what's also really neat is that you can usually even just see the timing of the onset. I mean, you can see sometimes even the activity goes down on the patient. At the same time, you get this atrial arrhythmia. You could see the rapid rates in AFib, and there's so much data on these devices that makes our life easier. And this also shows, so how much do you need to pace? So as much as possible is the answer, but the studies initially showed that if you pace 92% of the time, greater than that, that the outcomes were better than if it's, less than or equal to 92%. And then another study, said that, well, 98 sounds even better. It looks like the outcomes are even better in terms of, this was survival actually in this particular study. And so our guidelines said, this was the 2016 statement, that you should be a 98% or more, but it's really in the current world, it's as much as possible. So just in short, we have comprehensive approach to care, right? We have to make sure that we put the devices in the right people. That's a given. We're assuming that we program all these things, these different parameters, detection and SVT discriminators, program on ATP, that we, for CRT, that we certainly want to minimize RV pacing if you don't have CRT, and then you want to maximize your CRT delivery by making sure you're pacing a lot, making sure your rates are controlled in AFib if they're in persistent AFib, doing an AFib ablation if you want them back in sinus rhythm, and you don't want to do it, an AV junction ablation. Yeah, it's another way, but you want to be able to be sure that if you have CRT that you're pacing before you say they're a non-responder. And then, the patients, you want to look at the patient. how am I going to program that device so that that young active patient can still be active? And, you know, what about the things in their environment? You know, we tell them, you know, if they're, you know, around EMI, that, you know, that could be an issue, obviously. And then heart failure therapy has to be just the mainstay of treatment. So drugs, ablation, you know, we may need, and then we do need to follow them. And I think more and more of us are reliant on remote monitoring and less on inpatient visits. We'll talk more about that. And then in some people, I'll still do a stress test, not universally, but it's that really active young person who wants to do, you know, mostly that kind of young person who wants to do a lot of exercise. And I think that's all I have. Thank you.